Welcome to today's Explainer, where we're diving headfirst into one of the most polarizing debates in modern reproductive medicine, the management of male accessory gland infection, or MAGI.
We'll be relying strictly on recent literature from the Arab Journal of Urology to unpack a clinical divide that honestly has practitioners split right down the middle. I'm taking the stance that we are severely overdiagnosing this condition, while my co-host here argues we simply aren't doing enough.
Exactly. Are we dangerously undertreating a hidden microbial threat to male fertility? Because every day we hesitate, a patient's reproductive future is on the line. Or are we recklessly overdiagnosing benign conditions? Throwing heavy antibiotics at incredibly blurry clinical lines isn't just shooting in the dark, you guys, it's bad medicine. Let's break down the evidence from both sides.
Let's start with a staggering statistic that should frankly have every single clinician on high alert. Up to 50% of male genital tract infections are completely asymptomatic. They operate entirely in the shadows. This is a massive red flag for me. It means you have patients sitting in your clinic right now feeling perfectly fine while a localized infection is actively compromising their reproductive health and potentially risking transmission to their partners. We absolutely have to be proactive here.
And the stakes are incredibly high. The literature shows MAGI accounts for anywhere from 2 to 18% of all male infertility cases. So missing this diagnosis, it's not just some minor clinical oversight. It condemns couples to devastating, prolonged fertility struggles. When you really think about those numbers, it's obvious that hesitation is the absolute enemy of fertility preservation.
If we don't aggressively intervene, undertreatment leads directly to irreversible glandular damage. We are talking about permanent loss of function. Okay, but wait, what about our foundational medical principle, first do no harm? Aggressive intervention and overdiagnosis directly fuel the global crisis of antibiotic resistance. Not to mention, it subjects men to completely unnecessary, highly invasive procedures.
To really understand why blind treatment is so dangerous, we need to strictly define what MAGI actually is. As originally defined by Compire and his team back in 1980, MAGI refers to inflammatory disorders localized strictly to the male accessory sexual glands. So we're talking specifically about the seminal vesicles, the prostate, and the bulbourethral glands. It's a highly localized issue. And that is exactly why it's so incredibly difficult to pinpoint clinically without the right tools. Just think about the diagnostic overlap here. Our source material contrasts localized MAGI with broader male genital tract infections, or MGTI. Now, MGTI involves widespread infection across the entire genital tract: urethra, penis, testes, the whole shebang. The glaring problem? They share identical clinical markers, things like reduced semen volume and altered biochemical levels. It creates this massive gray area for misdiagnosis. You simply cannot justify heavy antibiotics when you can't even guarantee where the inflammation is actually coming from.
But you can't just ignore the biological damage happening at the microscopic level while you wait around for perfect clarity. Pathogens activate macrophages and lymphocytes, which releases this violent storm of cytokines and chemokines, and that leads to a massive spike in reactive oxygen species, or ROS. Get this, activated leukocytes can produce up to 1,000 times more ROS than spermatozoa. That causes severe lipid peroxidation, disrupted energy metabolism, and ultimately severe sperm DNA fragmentation. The destruction is very real and it's happening incredibly fast.
So, how do we catch this destructive process in time? We rely on leukocytospermia, or LCS. The World Health Organization clearly defines this as having more than 1 million leukocytes per milliliter of semen. Hitting this threshold is your critical red flag. It signals severe oxidative stress, and frankly, it demands immediate pharmacological intervention to save that patient's fertility potential.
But is leukocytospermia truly a definitive smoking gun? Come on, is an elevated white blood cell count in semen actually concrete proof that an infection is localized specifically to the accessory glands? Relying on this single metric as your trigger for long-term antibiotics is exactly how we end up shooting in the dark.
Think about all the completely non-infectious reasons a patient might present with elevated leukocytes: varicocele, a history of spinal trauma, even basic lifestyle factors like smoking, heavy alcohol consumption, marijuana use, or taking prescription SERMs like clomiphene citrate. All of these totally benign or non-microbial factors trigger an influx of leukocytes into the semen. Handing out knee-jerk antibiotic prescriptions based on one single semen analysis is incredibly reckless.
And the clinical symptoms? They don't make it any easier to justify an aggressive approach. The symptomatic presentation of MAGI, we're talking mild pelvic pain, ejaculatory discomfort, some urinary issues. It perfectly mimics entirely benign conditions, like benign prostatic hyperplasia, or just basic, non-bacterial prostatitis. The clinical presentation mirrors entirely different issues, making it incredibly easy to overtreat a patient who doesn't even have a bacterial infection to begin with.
Okay, but despite those overlaps, when we do identify a likely MAGI case, we absolutely must bring out a robust pharmacological arsenal to clear it. We are talking about empirical antibiotics like doxycycline prescribed for up to 28 days just to penetrate that dense prostatic tissue. And this is often combined with NSAIDs to reduce inflammation, plus fibrinolytics like bromelain at 160 milligrams a day. These work synergistically to help those antibiotics break through the tissues and reduce seminal fluid viscosity. It is a necessary, targeted response to a severe threat.
Necessary? Listen to the explicit warning directly from our source material, quote, "Prolonged courses of antibiotics and invasive procedures detrimentally affect patients' quality of life while contributing to the growing problem of antibiotic resistance," end quote. Prescribing a month of strong antibiotics without a definitive microbial culture takes a severe psychological toll on the patient and, quite frankly, a devastating toll on global health.
And what exactly is the cost of your wait-and-see approach? If you hesitate and miss that critical window to treat a true infection, the physical damage is completely irreversible. Chronic, ongoing inflammation leads to persistent pain, deep scarring within those accessory glands, and ultimately obstructive azoospermia. That means anatomical blockages in the seminal tract completely prevent sperm from ever reaching the ejaculate. That is the devastating reality of doing nothing.
All right, I think where we can both find some common ground here is that our current standard diagnostic pathway is just incredibly frustrating for everyone. Step 1 is a specific medical history.
Right, and step 2 is the semen analysis, looking for LCS and running cultures.
And step 3 relies heavily on imaging, specifically transrectal ultrasound, or TRUS, to identify structural abnormalities in the glands.
We completely agree on this part. The current pathway severely lacks the precision we both need to confidently end this debate.
The only way out of this clinical divide is by pivoting straight to the future. Relying on broad clinical criteria and basic peroxidase tests for leukocytes has got to be replaced.
Exactly. The future of MAGI management absolutely relies on transitioning to highly specific, molecularly targeted diagnostic tools. We need true precision medicine that finally eliminates all the guesswork we've been arguing about today.
These upcoming technologies will finally allow us to distinguish between a true microbial MAGI and simple benign inflammation. We're looking at gold standard immunohistochemistry using specific proteomic markers, like CD45 and CD53 antigens, to comprehensively detect those leukocytes. Add to that next-generation genomic sequencing to identify specific pathogen DNA, and actually analyzing the male genital tract microbiome to truly understand immune regulation in the tract itself.
But let's be real, those precision tools aren't sitting in every clinic quite yet. So we want to leave you with this final, provocative thought. Tomorrow, when a subfertile patient sits in your office with elevated leukocytes but absolutely no obvious symptoms, until we have those precision biomarkers in hand,
will your next prescription do more harm?
Or more good? Thank you for joining us on this explainer. Keep asking the hard questions, and we'll see you next time.